actually see how the whole process works. So without further ado, I'm going to welcome to the program Dr. Keith Robinson. Dr. Robinson, how you doing?
I'm well. Thanks for having me.
Yeah, thanks for coming. I always say it's this adventure of health just because we always try to bring the latest and greatest across South Florida and beyond.
Am I the latest or am I the greatest?
Both.
Oh, wow. All right, I gotta ask.
Definitely. So we have a lot to talk about. I want to ask you, I always ask pulmonologists to kind of explain COPD because I'll be honest, 5 years ago, like the story I was telling, I was a writer and doing a testimonial. I had no idea what it was. And I actually learned from the elephant sitting on the chest commercial, which I'm sure you've heard that term.
Yeah, you know, COPD is kind of a garbage bag acronym. It catches a large number of problems that lead to what we call chronic obstructive pulmonary disease. So that can be anything as simple as asthma, which is a chronic obstructive process, all the way to emphysema, which is more of an end-stage process or a significant loss of lung function. And so it's having airflow limitation, inability to completely exhale and empty all the air that you've inhaled into the lung, and that obstruction causes some folks to have shortness of breath.
I found that interesting when we were just talking in the green room that you mentioned asthma, because I would never think of asthma as something that falls under the COPD umbrella, as I guess.
I think COPD researchers are kind of tongue-in-cheek about it. I think maybe in the 70s, asthma was lobbied out of COPD as a diagnostic term at the NIH because, again, grant monies are hard to come by. And so I think the allergists did a very good job of lobbying their funds, and appropriately so, because we now recognize that asthma and COPD, even though they're both chronic inflammatory diseases, they set up shop differently in the lung, and so they really should be studied differently.
And yeah, I was telling you also the little story also, I didn't finish it because we were in a popular green room there with you in there. Everybody's happy to see you here, so that's great. But so I had a friend who actually grew up with asthma, and I feel like when we were, the parents were talking and whatnot at first, they were sent to an allergist, you know, and that was kind of, I never even thought pulmonary back then is something it's something I've learned recently. So that is something, you know, you learn something new every day. That's what I learned today.
Well, there's some folks who had significant asthma as child or young adult that, if poorly managed or not treated adequately when they were younger, leads to the more chronic fixed airflow obstruction that we see in more of our folks who are cigarette smokers that lead to COPD.
And I'm always doing this program, and I wanted to ask you, first part of the question, how big of an issue is COPD here in South Florida? And then if you could take us like nationally across the U.S., because every time I bring up this topic, I do a little research on it, and it's like one of the top 5 leading causes of death in the U.S. Is that true?
If we ignore medical error, meaning physician-level concerns and medical error, and get back to just medical, at least diagnoses, yeah, COPD is the 3rd leading cause of loss of life behind cardiovascular disease and cancer. And it's actually increasing, unfortunately. I think a lot of it is poorly recognized, as we're discussing. But I think the risk factors are still very prevalent also, which is a large number of patients are still smoking or vaping. And so I think we go a good number of years before folks actually get a diagnosis of COPD also. I think most people take about 2.9 years before they finally get a diagnosis, even though they've been symptomatic. But we know that COPD now affects close to 14 to 15, well, actually a little closer now that we've done better data, 16 million people in the United States. And we estimate that there's another 12 to 14 that haven't been diagnosed yet. And we also now recognize that COPD is more common in women than men. So more than about 56% of women now have a diagnosis of COPD. And so for us, the landscape of COPD is changing as we start to ask the right questions. And a lot of that has to do with what the CDC is doing every year, which is the Behavioral Risk Factor Survey, where they have a robocall that goes out and ask very specifically if you've been told if you have COPD, chronic bronchitis, or emphysema. And so the numbers are going up dramatically. And COPD is actually fairly prevalent in Florida as well. I think roughly 7% of the population in Florida has a diagnosis of COPD. So it's not an uncommon problem when patients end up in the emergency department or in our offices.
Obviously, when I hear the elephant in the chest, we all think of smoking. But you said something key there, and it's so popular right now, is vaping. We have a pulmonologist right here, Dr. Keith Robinson. I got to ask you that question because it's kind of down at the bottom, but is it true that like e-cigarettes can do harm as well? Because it seems to be the myth right now is like, it's kind of like, I hate to say it, the cool thing to do right now. You see vape shops everywhere.
I think the problem with vaping in and of itself is that it is still an inhaled treatment, meaning patients are treating their addiction by getting nicotine in through a vaporizer. And I'm not much of a regulatory type guy, at least not and I try to stay less political in my discussion, but our FDA really does need to help us out. And I think a large chunk of it is that we don't know what concentration of nicotine is in a vapor. And we know that the primary injury to the lung, and many, especially in young children and teenagers that start to vape, is that the nicotine causes constriction of the vessels of the lung. And when you cause constriction of those blood vessels, you don't develop normal lung. So we can see in some children that vape and some adolescents that vape early suggestions of COPD before they've actually developed a full set of lungs. More importantly, vaping is still an inhaled therapy that can cause some injury and inflammation. In fact, article out today in the Respiratory Medicine demonstrating again that the same level of concerns that we see with cigarettes, we can see with vapor, meaning that there's now secondhand vapor smoke that can cause injury to the lung. And so I think there's a large amount of work that still needs to be done in addressing whether vaporizers are safe, but the early suggestions are that it's just as dangerous to the lung as regular cigarettes.
I thought that right away when I saw it popping up and it on the rise. I thought to myself, this can't be something that's going to be beneficial or safe. We've all been at a sporting event, walking in or something, or out in public, and you get behind that person, and it's the big cloud of vape smoke, and actually doesn't actually smell as bad as cigarette smoke. I've walked through a couple clouds, not wanting to, and you just smell it there. But yeah, I always thought to myself, that cannot be good.
It's just nicotine, it's a safe substance. Then that's the, I think the double-edged sword of nicotine is it's very safe, but it's highly addictive. And I think the idea that so many patients and some of my clients that actually vape are doing so to get away from cigarettes is one thing. I think there is some study that suggests that, again, vapors may allow some folks to come off of more formal cigarette smoking and maybe get to a point where they're no longer smoking at all. But we see that a large number of patients that use vaporizers are still actively smoking. And so it's really just switching one behavior for another, which is how are you getting your addiction settled? And I think the idea that we really separate behavior and addiction separate in our office means that we really can tease out who's really trying to get away from the cigarettes versus who's really treating the nicotine addiction that unfortunately causes some people to get sick.
Definitely. And we're here with Dr. Keith Robinson. Let's talk, he's a pulmonologist. Let's talk a little bit about your office. So Fusion Health, great website. I'm on it now. Very easy to navigate, ton of information as well. So what is Fusion Health, your practice? What happens there?
Fusion Health. So I parked my private pulmonary practice inside of Fusion Health. Fusion Health is our pulmonary rehabilitation center. We do a phase 2 pulmonary rehab. And the reason we named it Fusion, and Dr. Lauren Lira is my associate, the clinical director, is that, there were a lot of things that our folks with COPD were worried about, or more importantly, had to travel to multiple locations to get accomplished. Their exercise capacities improved, titration of the medications, and a lot of them came with musculoskeletal limitations and pain, arthritis essentially, which is, by the way, the #1 comorbidity associated with COPD. And arthritis, so a lot of our folks, a lot of our folks have joint pain. And so when we thought about what we wanted to do in our rehab, we started thinking about the things that patients said that they needed. So Dr. Lear actually came to us as an addictionologist. So she's actually a chiropractor by training, but does a lot of substance abuse and counseling. And I think for us, it was how do we get our patients with musculoskeletal limitations and pain that were on opioids off of their opioids so that we can get them up on a treadmill, get them through Tai Chi, get them through yoga, get them maybe onto Pilates, so that they're able to get physically fit with also getting away from the substance, at least opioids in general, that was causing them some harm and not helping them to get better. And so as we started thinking about the substance abuse concerns, we started adding physical therapy, occupational therapy. And so again, the idea for us was that we fused together all the things that patients stated they would have needed out of at least an office visit in order to felt like they got something accomplished. And so for us, we do a good amount of the same things that they would get at a formal pulmonary rehab like the one here in Boca. Boca Community has also a very good pulmonary rehab. I'm not trying to give them more work than me, but I think the idea is I like folks, if they've got the ability to get to pulmonary rehab, to find a center that's closest to them. But we added some things to our pulmonary rehab that others don't. And I think for us, it's pain management. Dr. Lear does acupuncture with some. Again, we've already discussed the substance abuse that she does. But we also have occupational therapy. Some of our folks getting their activities of daily living accomplished through the day can be very difficult. And so we've added an occupational therapist the last couple of weeks here who's going to be helping us to hopefully get our patients through the day just to accomplish the things that they need to.
And where is Fusion Health located? Is it in Broward County?
Yeah, we're in Broward County. We're in Oakland Park,
Okay.
right, not too far from Milton Manors, not too far from the Galt Mile. So when we thought about where we wanted the office to be, we centered it about 5 miles from 6 hospitals. The idea being that it's easy for folks to get to us on Oakland Park Boulevard from 95 or from Federal Highway if they're coming from the east side of town. But we also wanted to make sure that people, if they were going to these other hospitals, had at least a center that was going to be not too far from where they end up if they have any complications or concerns. So that, again, if they're being discharged out of those facilities, they're hopefully going to be caught by us and we can help them.
Definitely. And so how far was it from here for you to travel from there today to the studio? We're here in Boca Raton, South Boca Raton, right next to Delray Beach. So a good 30 minutes, 45 minutes at the most, right?
It took me about 25 minutes.
25? Wow, we like to hear
that.
that.
I caught the lights really well today.
That's great. So listen to that. We're here in Boca Raton, and this is only 25 minutes away, and it's Fusion Health, and they have Tai Chi, cardiopulmonary exercise testing, pulmonary function testing. This is for a lot of maintenance. Because one thing I heard or I read one time about COPD is it's something that really can't be cured, but if you work on it over time, it's something that you can maybe maintain the level you're at and kind of improve the quality of your life.
Yeah, as I stated earlier, people will go almost 3 years into having symptoms of COPD before they get to a doctor that makes a formal diagnosis. So that means that 3 years folks have gone, if they were fairly active, to being less active, more sedentary, sitting on the couch more. And so for us, the idea is that in that 3-year process, patients have generally lost a large amount of exercise capacity. And so we do a good chunk of retraining, or reversing some of the deconditioning that patients have. As I said, we've added the occupational therapist because I think putting away groceries for some can feel like running a marathon. And so the idea that patients have a large degree of limitation means that for the first couple of weeks, we're really trying to reverse some of that early deconditioning that causes folks not to be physically active. A huge part of the breathing issues are making sure they're on the right inhaled therapy. Some folks are not adequately, or at least on the right maintenance therapy for them, depending on what their lung functions are like. So we do spend some time trying to figure the right medication for patients to inhale. So again, we can relieve some of that shortness of breath that patients have when they're doing their activities. And then, I think if there are oxygen concerns, some folks come to us who are teetering on whether they need oxygen or not. And so we try and assess that very early so that as we're starting to do the exercise capacity improvement, we can provide oxygen if that's necessary.
And you mentioned medication, and that kind of circles back right from where we started with the elephant on the chest, because I was just looking today because I knew about the elephant on the chest commercial. So I actually did a little search. It's a Symbicort TV spot as well. Yeah. The wolf huffed and puffed, and I remember seeing that one recently, and that's another COPD commercial. So obviously you're helping with the occupational therapy and the physical therapy, and you can order that as a physician, the pulmonary rehab, the maintenance, it's like working out. Now I've seen it worked out in a peer group, but there's also the opportunity, like you said, there's some medications that can help in certain stances as well. So it seems like there's a lot more options open by offering something like Fusion Health than maybe you're not getting elsewhere.
Well, I think that was the other thing, too, is that, being a private pulmonologist, I'm actually in a group called Pulmonary Physicians of South Florida.
Okay.
So there are 39 of us in that practice, spread out through Miami-Dade and Broward. And I think the idea was that so many of our folks meet the standard for pulmonary rehabilitation, but there are 3 centers that I know of, formal pulmonary rehabilitation centers between Miami-Dade and Palm Beach County, and we're one of them. And so I think the idea is that there's a lack of a large number of facilities that can help a large number of folks with COPD. And so for us, it was providing the standard of care. If you go anywhere else in the world and you have a problem like COPD, you're going to be referred to pulmonary rehabilitation. The honest answer is, and I have to be honest, only 1% of folks actually make it through pulmonary rehab, which means that there are a large number of folks, even if they have a referral to rehab, who don't make it. And so for us, it was changing the paradigm of a pulmonary rehab to something that looks like a gym, meaning treadmills, bikes, and really trying to introduce a lifestyle change. And that's why the Tai Chi, the Pilates, the yoga. Because I think the idea is that physical activity is physical activity if you find the right kind for patients. And so for us, it was reintroducing physical activity in something that might benefit, meaning a new lifestyle, a new way of getting some physical fitness without having to feel like you were becoming gym fix or having a Jane Fonda moment. Because I think a lot of our folks didn't have gym fix moments. They didn't have Jane Fonda tapes. And so trying to show them how to do that type of activity didn't benefit. And so I think what we're hopefully reintroducing is that there are lots of different types of activity. And the idea is just to get up and move. Because I think, the mantra that we know is that if you're moving, you're living. And I think the idea that so many of the studies that have come out recently have demonstrated that when patients are physically active, meaning making at least 5,000 steps per day, they're going to live longer than if they're not making at least 5,000 steps per day. And so those are the things that we try and teach our clients when they come through the office, which is, we're not just trying to reintroduce physical activity, we're trying to reintroduce a behavior, which is lifestyle change, more importantly, being physically active, eating healthy, maybe addressing some of those arthritic conditions as we were discussing, so people feel like they're getting at least more accomplished.
And yeah, if you were a family member or friend, they're not able to make it up the stairs, maybe, or they're not enjoying the quality of life they used to. Check Dr. Robinson's FusionHealthSouthFlorida.com, Dr. Robinson and Dr. Lauren Lira as well. We're going to take a quick break, and on the other side, talk to Dr. Robinson a little bit about IPV treatment on the How to Stay Healthy show. How to stay healthy. It's a question asked by many people and answered by few. On How to Stay Healthy with David DePino, I'm going to bring you the latest in health news by interviewing top doctors from South Florida and around the world. Tune in on Fridays at 5:30 p.m. right here on WWNN Radio 95.3 FM and 1470 AM, the Health and Wealth Network, to hear the latest health treatments and my curveball question of the hobbies and passions in life doctors pursue when not providing medicine.
All County Healthcare, Inc. is locally owned and operated, serving the Tri-County area, Palm Beach, Dade, and Broward counties for the last 25 years. The practice of medicine is changing dramatically. All County Healthcare, Inc. still does it the old-fashioned way, where our nurses and healthcare professionals come into your home to service your medical needs, providing you the fastest and best care possible. For more information, call 954-717-7027. And remember, Medicare Home Care is covered by Part A of Medicare with no out-of-pocket cost to you. It's your decision, and only your decision, on what healthcare agency you use. Call today. All County Home Health Care, Inc. at 954-717-7027. License 200999096.
And now back to How to Stay Healthy, your weekly doctor's interview and prescription to better health. Hello, South Florida. Thanks for coming back. We're here with Dr. Keith Robinson, FusionHealthSouthFlorida.com. He's a pulmonologist. We talked a lot about COPD, started out with medications, but I want to ask you again if you could give us a little bit more about the medications available for COPD.
Yeah, I think, and if their doctor's listening, they're probably familiar that the way that we treat, the paradigm that we use to treat patients with COPD has changed dramatically in the last 5 years. We used to classify folks as a GOLD level 1, 2, 3, and 4. GOLD is global obstructive lung disease. And it's an initiative that allowed for us internationally to decide which inhaled therapies were appropriate for patients based on how badly or how much airflow obstruction was present. But we learned that a large number of folks, regardless of how bad their lung functions were, some folks did really well, some folks did really poorly. And so when we started paying attention to how symptomatic patients were, more importantly, how many times they've had exacerbations, it really allowed us to classify folks into a phenotype, a way to classify folks based on what their risk factors of having an exacerbation are. And so we now classify folks A, B, C, and D. And so in general now, when we have folks either B or D, and that's 80% of folks in the United States are going to be a Gold B or a Gold D, we try and find long-acting maintenance therapy that's going to last at least 12 hours to 24 hours. And I think the other thing we've learned is that, and I do work with the COPD Foundation, I'm one of their clinical advisors, is that we recognize that sometimes doctors pick the wrong inhaled therapy, meaning we choose the wrong device, we choose the wrong agents that are within the medication devices, or we choose the wrong route of delivery. And I think the idea that some of our patients are probably telling us that the medications we're choosing aren't appropriate is what we do in pulmonary rehab, is we go through very specifically whether the delivery of the device is correct, whether the route of delivery is correct, whether the medications that are within the inhaler are correct, so that we can send those patients back to their doctors on the correct medication.
Very important. Thanks for explaining that. And you mentioned devices, and now when there's that congestion in the chest, it needs to be broken up, and I think you said before exhaled. What is an IPV treatment? Because we've had a couple respiratory therapists on the show. And so what is the IPV treatment? And the second part of it is how can it be effective?
So IPV therapy is a way of giving an oscillatory breath. And so it's a treatment that allows for us to mobilize secretion without having to use, say, PEP devices, positive expiratory devices that actually force patients to cough. So this device wouldn't force a patient necessarily to cough, but it uses frequency waves to actually get down to the small airway where COPD lives. So COPD doesn't live here in the center part of the chest. It lives all the way out towards the armpits. We call that the small airway. And the small airway can have a large amount of resistance. And so the idea with IPV therapy is you're providing a large amount of frequency down at the frequency where that resistance is located. You can deliver nebulized medications via the IPV device, but more importantly, you can mobilize secretions, or at least with the frequency, you can mobilize the secretions out of the small airway, so you can minimize the amount of mucus and phlegm that's located that far out into the lung. So the idea is that in some patients, the resistance that causes them to be short of breath is not constriction or narrowing of their airway due to muscle contraction. It's actually due to secretions. And so the idea behind IPV therapy is to minimize how much secretion is located that far out in the lung by mobilizing it back towards a larger airway so you can cough it out, so that, again, we can improve the resistance that causes some folks to be short of breath.
Yeah, those are the branches out, right?
That's correct.
That's the first thing I was thinking when you said that and did that with your hands. I thought of the branches. Wow, that's way out there. So it's not where you nailed it. I was thinking it was right here, like the elephant right on the middle of the chest. But it's in the branches.
It's in the branches. That's correct.
It needs to get into there and get out.
Yeah, so COPD, we've learned so much in the last decade about COPD that was wrong prior to. And I think the idea that we treated as many of our patients with COPD like asthmatics is why, again, we have that separation. Because COPD is more of a peripheral, more of a lung disease that's all the way out towards the ends of the lung. And that's where, unfortunately, folks get the damage to the lung. They get the chronic inflammation of the lung. But more importantly, that's where the medications work. And so for us, that's why picking the right inhaled therapy is appropriate, and it needs to be titrated, because if you can minimize the constriction, the narrowing of the airway due to constriction or secretions, you can improve the resistance. And if you can improve the resistance that moves air in and out of the lung to a point where patients are able to move more volume of air with each breath, they're going to feel less short of breath. So that's the goal of therapy, is to allow folks to minimize the resistance that's causing them to have, unfortunately, stale air blown up like a balloon sort of phenomenon, so that they're able to move all that air out of the lung.
Yeah, and then they're going to have a better quality of life because of it. We always say that word, quality of life. Going back to the causes of COPD, something I'm thinking about in South Florida, there's a lot of construction going on in the Miami sector, Fort Lauderdale, West Palm Beach. Obviously, with construction, there's environmental hazards. And going back in the day when, Miami was built up, I knew a painter, and he had actually gotten COPD from sandblasting. So there's also environmental causes of COPD and other lung ailments as well, correct?
Yeah, I think we wrongly associated just smoking as a cause of COPD. So now globally we say biomass fuel exposure. And so for some of our folks from Latin America, that could be something as simple as using wood to heat and cook food, or heat the home, or coal in some parts of the world to heat and cook food. So that biomass fuel actually causes the same level of injury that a cigarette would. So the idea is we're not supposed to burn carbon. And so for burning carbon and putting it into the lung in any fashion, that's what's going to cause some harm. But occupational causes, like you're describing, also are some of our folks work in dusty environments, and that dusty environment that they work within can cause chronic inflammation. And for the lung, when something gets down into the periphery, the small airway of the lung, it only has one way to really try and help, and that's to send more white blood cells to that area to see if it can digest away all that particulate matter that gets down to the lung.
Definitely. So I just wanted to bring that up. Yeah, there are a lot of causes, but there's a lot of great pulmonologists here in South Florida, and Dr. Robinson is one of them, fusionhealthsouthflorida.com, and I'm going to give his number out as well, 954-900-5635. I promise to give that away out again before the end of the show. I wanted to ask you, I just recently attended a few Grand Rounds programs. I work in the PR world in the healthcare industry, and I find them fascinating. And you were telling me you do CME Grand Rounds, and you're about to head out to do a Grand Rounds. Is it up in New York?
Brooklyn, yeah.
Brooklyn.
Next Thursday, up in Brooklyn. So I've done, for I'd say probably the last 4 years, I've been invited by the COPD Foundation and Rock Point to help with Grand Rounds at re-education about idiopathic pulmonary fibrosis, But most of my talks are actually centered on COPD. And I think the hotbed topic lately has been hospital rehospitalizations due to COPD. And I think what we're learning is that not only are some physicians not aware that hospitalization due to COPD is a problem, at least they're not aware until after the hospitals start to send out notices that the hospital is being penalized. And so I think the concern that we have is there are a large number of folks with COPD that go home from their hospitalization and they don't get better. And I think that's what we go out in the grand rounds to do every lunch period, is to remind doctors that there's certain things that we can do within the hospitalization, but more importantly, certain things we can do within the first 2 weeks after a patient is discharged to home to help them feel better. A lot of that, believe it or not, is the IPV therapy that we've been discussing, which is some folks go home and they still have a large degree of secretions that need to be managed. And so we really try and make sure that in that first 2-week time frame, patients have had a visit with a physician, or at least a phone call to let them know that they're doing well, make sure they're on the right inhaled therapy. Some patients can't inhale dry powder therapy immediately after discharge, but so many patients are sent home with a dry powder inhaled medication. And so that's poor compliance because of, again, choosing the wrong agent and the wrong delivery. And so that in some patients causes them to have to go back to the hospital to seek a treatment. And so the idea is that there are things that we can think about within the first 48 hours of discharge that might benefit patients that will hopefully keep them home and not going back to a hospital.
We got about 45 seconds. Are you from the Northeast?
Yeah, I'm from Philadelphia.
Oh, wow. So you were telling me in the green room you're a big lacrosse player. You played pro?
Trust me, lacrosse is one of those things that if it's on TV, I'm sitting and I'm watching.
Yeah.
I can't get away from it. It's one of those hobbies of mine that, you know, honestly, I joke about picking up a stick, but, you know, I'll play if I got an opportunity to do so.
And shout out to Coach Finn. I'm going to send him this. Coach Kevin Finner in Delray Beach.
Yeah.
I'll send him
Coach
this. We'll
Finn,
get him
yeah.
in here next time.
Kevin and I, we go
Will you
way
come
back.
back if I get Kevin in here?
Yeah, absolutely.
Okay.
I love Finn.
There you go. Join us next time on the How to Stay Healthy show. Thank you, Dr. Robinson.
Thank you for your time.
For a prescription to better health from the top doctors in the medical fields of cardiology, neurology, orthopedics, sports medicine, and primary care, join us each week on the How to Stay Healthy show.
The opinions expressed on the preceding sponsored program were strictly those of its host.